Hello everyone, I'm Dr. Lisa Bagnall from We Teach Nursing. Don't forget to stop by my Facebook page, We Teach Nursing, especially if you have any questions. I may have some PowerPoints on there for you as well. Today we're going to talk about electrical and pharmacological treatment of various dysrhythmias. In order to understand how these drugs work, you need to understand certain key terms. For example, inotropic refers to the force of contractility or force of a contraction, and that directly affects stroke volume. So if I give a drug or administer a drug that increases contractility, I'm giving a positive inotropic drug. For example, epinephrine and dopamine both have positive inotropic properties. If I give a drug that has negative inotropic properties, it's going to decrease the force of a contraction. Metoprolol is a beta blocker. It can also decrease the force of a contraction and conserve oxygen for the myocardium. Chronotropic refers to drugs that alter the heart rate. Think of your watch as a chronometer. It tells time. Therefore, if you're giving a chronotropic agent, you're giving something that's going to alter the heart rate. Something that has positive chronotropic attributes will increase the heart rate. If you give atropine or epinephrine, you're going to increase the heart rate, and therefore that has a positive chronotropic effect. Beta blockers and calcium channel blockers have negative chronotropic properties, and therefore they decrease heart rate. There are differences also when you're talking about electrical therapy and cardioversion versus defibrillation. When you cardiovert a patient, you're going to give a synchronized delivery of an electrical shock. In other words, you're going to attach the EKG electrodes from that monitor / defibrillator, and when you press the buttons to deliver that current, the machine itself will detect the upright QRS complex and deliver the shock on top of that QRS complex. And this is important because you want to cardiovert patients when they have a very fast rhythm but they have a pulse. For example, VTAC with a pulse, atrial fibrillation with a high heart rate, or for a planned cardioversion, and so forth. Defibrillation is different in that you don't have to have the patient hooked to that monitor that has a defibrillator / cardioverter. As soon as you push the buttons to deliver the shock is delivered. It does not detect anything. It just delivers the shock as soon as you push the buttons. In that situation, you would use it for pulseless tachycardia such as VTAC and VFib. There are differences also between defibrillators. Most current defibrillators are biphasic. In other words, they deliver shocks in more than one direction. And when it does that, it requires less energy or joules to be effective. So most of your biphasic defibrillators go up to 200 joules. Your monophasic only delivers shock in one direction. Those defibrillators are preset from anywhere from 100 actually to 360 joules. Always remember though, if the defibrillator is indicated for the patient but is not readily available and the patient is pulseless, i.e. pulseless VTAC or VFib, please implement CPR until the defibrillator is available. Before delivering the shock, whether it's cardioversion or defibrillation, make sure that no one is touching the patient or the bed. Yell clear and visually make sure that no one is either touching the patient or is in the area. Because if someone else gets shocked and you delivered that shock, you are legally responsible for the damages that are incurred to that patient or that person. Always resume CPR immediately after shocking the patient when the patient is defibrillated in a pulseless state. For example, if the patient's in VFib and you defibrillate them immediately, even if it shows normal sinus rhythm, resume CPR, because the theory behind that is that even if they return to a normal rhythm with a pulse, the cardiac output will still be low. Now, if they wake up right away, of course, don't start CPR because they have enough of a blood pressure to perfuse the brain. Again, like I said, cardioversion is the same except that the shock is delivered on the top of the QRS complex. And this is why you have to have the monitor that has the defibrillator / cardioverter hooked to the patient so that it can actually sense the patient's rhythm. It reduces the chances of VFib in patients that are perfusing. So if a patient is in rapid AFib or is going for an elective cardioversion in atrial fib or is in VTAC with a pulse, cardioversion is indicated. Energy levels may be set lower, especially in patients with atrial dysrhythmias, because it often takes less energy to convert those patients into normal sinus rhythm. You will notice that throughout this PowerPoint I have selected various YouTube videos that really help to drive home these points. So I encourage you to look at these as well, and they will be available on my Facebook page, We Teach Nursing. Many of the drugs that are given for resuscitation and for patients who are in the critical care setting affect the adrenergic nervous system. So in order to understand how the drugs work, I decided to break down the different receptors of that system so that you understand that when you read about these drugs, you know how they work. You don't just memorize what they do. So under the adrenergic nervous system, you have the sympathetic and the parasympathetic nervous system. The sympathetic nervous system basically speeds things up. So when we talk about that, we have different receptors that work differently in the body. Alpha receptors are found in the artery, and when you think of alpha, think of A equals alpha equals artery, that when they're stimulated cause vasoconstriction. Norepinephrine is a very strong, has very strong alpha properties, so that when you give norepinephrine, you expect a lot of vasoconstriction. Beta drugs work a little bit differently. They're separated into two different types of receptors. There's beta 1 that are primarily in the heart, and beta 2 that are in the bronchus and in the peripheral vasculature. So think of it this way. You have one heart, beta 1, and two lungs, beta 2. So when you're giving a beta drug, you increase contractility and increase automaticity or heart rate. Therefore, you have increased inotropic and chronotropic properties or activity. If you're blocking beta or you're giving a beta blocker, you're decreasing contractility and decreasing automaticity. And just by that principle alone, can you not see where you would have to be careful when giving a beta blocker to someone who has congestive heart failure? Because it can put it into that person into worse failure. Or it may actually help them. There's a fine line. Beta 2 receptors are primarily found in the bronchus and also in the peripheral vasculature. When you stimulate beta 2 receptors, you cause bronchodilation. And when you block them, you cause bronchoconstriction. So think of it this way. A patient gets stung by a bee and they have an anaphylactic reaction. You give 0.3 milligrams sub-Q of epinephrine. You're not giving it for the beta 1 properties, you're giving it for the beta 2 properties, which is bronchodilation. Think about the COPD patient, where in the literature it says use cautiously, beta blockers cautiously with those with COPD. That is because it can cause bronchoconstriction or bronchospasm. Now, the current literature says that that is a fairly rare event, and you know, if the patient has COPD and they've been on beta blockers, I would not question giving that beta blocker. However, if it is a new prescription for a beta blocker, I would watch that patient closely. And if they developed wheezing, I would notify the provider immediately. The last receptors I'm going to talk about under the sympathetic nervous system is dopaminergic. Those are receptors that are found in the renal and mesenteric vasculature, in the arteries in particular. When stimulation of these receptors occurs, it causes vasodilations only in those areas. And the only drug that I really know that does that directly is dopamine at 2 to 5 micrograms per kilogram per minute. Many oftentimes dopamine was given at 3 mics per kilo per minute in that renal area, renal dose area, in order to enhance renal perfusion. The literature is mixed. Some of the literature says that that will increase renal failure, and there are those that still believe that it will help to prevent renal failure. So you may see two schools of thought clinically. The parasympathetic nervous system is the opposite. Stimulation through the vagus nerve is how this is activated, and it slows things down. Think of vasovagal. Let's say a patient comes in supraventricular tachycardia or PSVT. The first thing you do is you ask the patient to take a deep breath, hold it, and bear down like they're having a bowel movement. That is in order to stimulate the vagus nerve, and sometimes that is all is needed in order to break that dysrhythmia. In my experience, it rarely works, but it is still tried. Critical points to remember: if the patient is pulseless, all the ACLS drugs in the world will do no good without effective CPR. Pulseless VTAC or VFib require early defibrillation in order to put that patient into a normal sinus rhythm. If that and that is the priority. So if you see that on your ACLS tests or on the NCLEX question, early defibrillation is the priority. However, common sense should tell you that if the defibrillator is on the other end of the unit and you're right there with your patient, you need to do CPR until that defibrillator is available. Remember, ABCs. Also know that most people who develop asystole will not survive unless the cause is found and corrected. And even if it is, a lot of times the patients won't survive. Always assess your patient first. Know that machines break down, they're not always accurate, or they just don't take place of assessment. Know the patient's code status. That is so critical. When you come on and you receive report from the previous nurse, if that nurse does not know that patient's code status, you need to get into that chart and find out, because it would be kind of tragic to resuscitate a patient who is a no code or not act on a patient that is a full code. That's even worse. Never panic in an emergency situation. It does not make you move any faster. Slower and methodical is better than fast and chaotic. Trust me on that. Not everyone will survive a cardiac arrest. It doesn't mean that that's your fault. Pay extra attention to a patient who tells you that that they're not going to survive or that they're not feeling right. The patient knows their body better than anyone else. And surgeons are very clued into this. Most of them are anyway. If a patient tells a surgeon, "Oh, I'm not going to survive this operation," 9 times out of 10, that surgeon is very nervous about taking that patient to surgery. Patients know. They absolutely know what their body is doing and when something is not right. Be open to change and evidence-based practice. For example, there are facilities that allow family to be present during CPR. And I have actually worked in a facility that allowed that, and believe it or not, it's a good thing if it is appropriate. In other words, if the family wants to be there, because it shows them that the staff have nothing to hide, and many oftentimes it gives them peace of mind because they know everything in the world was done to help their loved one, especially when the efforts are futile. Treating SVT and PSVT, adenosine is the drug of choice. It is a naturally occurring nucleotide that has antiarrhythmic properties. It rapidly interrupts conduction through the AV node and allows the SA node to reset itself. It actually interrupts the influx of calcium. And the AV node is dependent upon the influx of calcium for its conduction. So if you all of a sudden halt conduction through the AV node, sometimes it's enough to allow the sinoatrial node time to reset itself and restore normal sinus rhythm. The good news is the half-life is approximately 9 seconds. So if you see a short period of asystole when you give adenosine, which is very common, know that that is short-lived. And believe you me, it seems like it's going on for a minute when you see it, but honestly it's only 9 seconds. You have to give it rapid IV push. You either have to have the flush hooked up at the same time or an IV running quickly to get it to the heart as quickly as possible. The dosage for adenosine or adenocard is 6 milligrams. And then if it's ineffective, a minute or two later, you give 12 milligrams. And then in another minute or two later, another 12 milligrams. You can only give up to 30 milligrams. So it's 6, 12, and 12 very quickly, as rapidly as possible. Some patients may feel a sense of doom or have dizziness or severe chest pain when given adenosine. Now think of it this way. If you have a 9-second period of asystole, you're interrupting conduction and circulation to the heart for 9 seconds. That is why. There is a video link attached to this particular slide that shows the administration of adenosine, and it's extremely valuable, and I will place this on my Facebook page so that you can view it. It really really helps to put a picture to this slide. It helps you to learn it. Now, epinephrine, which is also known as adrenaline, has both alpha and beta receptor stimulation. So that means it causes vasoconstriction, increased contractility, increased heart rate or automaticity. So think of it this way. If you're pulseless, then epinephrine is indicated, period. It's used for VFib, pulseless VTAC, unresponsive to defibrillation, and asystole. It's also used for pulseless electrical activity where there's a rhythm electrically, which may be normal sinus rhythm or AFib, doesn't matter, but there's no pulse. It's given in a 1 to 10,000 solution. That means 10 milligrams equals 1 milligram. There is also, and if you look at that, that's this Bristol-Eject here. That's given IV push normally. But there's also the 1 to 1,000 solution. That's 1 milligram and 1 ml instead of 10. And that is the solution that you use to give sub-Q. And you would give about 0.3 mLs subcutaneously for someone who's in anaphylactic shock. That would be the same as giving 0.3 milligrams or 300 micrograms. And believe you me, giving that sub-Q, the patient will probably shiver a little bit. They'll become tachycardic, become very nervous because of the effects of the beta on the heart. And also on the alpha, it causes vasoconstriction. But the reason to give epinephrine sub-Q, which I talked about earlier in this particular video, was for the beta-2 effects. Always remember, if you're pulseless, CPR is indicated. Drugs will not circulate without proper CPR. So in a cardiac arrest situation, you're going to give it IV push. Epinephrine is also given as a continuous drip at 2 to 10 mics per minute, or 0.01 to 0.05 mics per kilogram per minute, depending on how your institution chooses to administer it. If it's based on weight, then it's mics per kilo per minute, and if it's not, which epinephrine truly is not in the adult, a weight-based drug, then it's usually 2 to 10 mics per minute. And we talked about the sub-Q administration of it. Now, norepinephrine is known as Levophed. It has stronger alpha stimulation, so it's a stronger vasoconstrictor. So for someone who's in septic shock, or as a vasodilatory shock, norepinephrine would be a better drug to give as a drip over epinephrine. A pure alpha drug would be neosynephrine. Norepinephrine still does have some beta stimulation, so increased heart rate, increased contractility. It is never given IV push. It is always given as a continuous drip at 2 to 10 mics per minute or 0.1 to 0.5 mics per kilogram per minute. Never give IV push. Atropine sulfate is an anticholinergic. It inhibits the parasympathetic nerve impulses, so it blocks the attachment of acetylcholine. And in cardiac tissue, it lowers acetylcholine, and what it does is it helps increase discharge from the SA node, and it increases automaticity between the SA node and the AV node, but it doesn't work below the AV node. So it's given for symptomatic bradycardia and heart blocks, sinus bradycardia where the blood pressure is low. Never, ever, 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 ever give less than 0.5 milligram or 0.5 milligrams, or it will worsen the bradycardia. It acts as the opposite. The maximum dose is 0.4 milligrams per kilogram, which is usually 3 or 4 milligrams total in the adult. It's also given in pulseless electrical activity when the rhythm is bradycardic as well, when the electrical rhythm is bradycardic. But again, epinephrine is first. If you're pulseless, epinephrine is indicated. Now we're going to talk about the different classes of antidysrhythmics. We have class 1A, which slows down repolarization by inhibiting the efflux of potassium. Quinidine is one of those drugs. Norpace is another one, and that is used to convert AFib, Wolff, Parkinson, White, PSVT, PVCs, and VTAC. They can also lengthen the QT interval. See, this is one example where, you know, it brings back that original point I put in the first PowerPoint in the series, where you must always also look at the QT interval in your patients, not just the PR interval and QRS, because these drugs directly lengthen the QT interval and can predispose the patient into torsades if that QT interval gets too long. It can also have a negative inotrope effect and cause heart failure as well as hypotension. Class 1A. Class 1B increases the efflux, or the potassium efflux, and it causes an increase in the speed of repolarization. It decreases the length of time for a cell to depolarize and shortens the refractory period. Examples of those drugs are lidocaine and mexiletine, and they're used for frequent PVCs, VTAC, and VFib. Class 1C prolongs depolarization, which means it slows down depolarization, but does not affect repolarization. Flecainide, Tambicor, Rhythmol, these drugs are used for paroxysmal atrial fibrillation, Wolff, Parkinson, White, and lethal ventricular dysrhythmias. Class 2 drugs are beta blockers. So class 1, A, B, and C affect electrolyte movement. Class 2 are the beta blockers. They decrease contractility and automaticity, so they decrease heart rate and contractility. Metoprolol, propranolol, and esmolol, that's the slow or short-acting, not slow, but short-acting beta blocker. It's used for AFib to control the rate, PSVT, frequent PVCs, and life-threatening ventricular dysrhythmias. Also, beta blockers are indicated for those who have had an MI to decrease the chances of sudden death. It increases the ventricular fibrillation threshold, and that's why. And that is a core measure for MI care. Side effects, when you look at a drug, the side effects are kind of looking at too much of a good thing. So if it decreases heart rate, one of the side effects would be bradycardia. Another one would be hypotension, shortness of breath and wheezing, especially in COPD patients. You have to excuse my dog. He's chasing dragonflies. So we're just going to have to put up with him, I guess. Class 3 drugs are potassium channel blockers. An example of that would be amiodarone. Amiodarone is also used to convert atrial flutter and atrial fibrillation. It's commonly used in the open heart unit after a valve replacement. And the reason for that is approximately 30% of patients who undergo either aortic or mitral valve valve replacement convert into atrial fib. And so it's used for a short time to convert that patient back. Again, that's a witnessed AFib, not an unwitnessed AFib. Amiodarone can also be used in life-threatening ventricular dysrhythmias, as well as those with frequent PVCs that cause hemodynamic compromise. But know this, amiodarone now can, even at smaller doses, can cause pulmonary fibrosis and liver failure, and oftentimes patients are limited to a 6-month period on this particular drug. Covert you will see more frequently for converting patients from AFib to normal sinus rhythm. It does this by delaying repolarization, by slowing the influx of sodium. And regardless, the QT interval for these drugs are the most significant parameter to look at and to monitor, because too long of an interval greater than 0.50 or QTC greater than 0.44 can cause sudden VTAC torsades. Class 4 antiarrhythmics are calcium channel blockers, and again, the AV node is dependent upon the influx of calcium for its conduction, so slowing conduction through there slows down the ventricular rate, and it is used primarily for atrial dysrhythmias such as SVT, AFib with RVR, which is rapid AFib, AFib greater with a heart rate greater than 100, and atrial flutter. Diltiazem is the drug most frequently used in that situation, but occasionally verapamil is also used, but primarily for SVT, unresponsive to adenosine, for example. It's always important to monitor the heart rate and blood pressure of a patient who's receiving any antidysrhythmic. Calcium channel blockers, like I said, are used to control the ventricular rates in those in A-flutter and A-fib. On a chronic care basis, they're used as anti-anginals in patients with unstable angina. And just as with beta blockers, calcium channel blockers can also lead to heart failure in patients with cardiomyopathy. It can also improve the heart's myocardial oxygen consumption or demand, but it can also, too much of a good thing can lead to worsened failure. We talked about adenosine before. It's used for SVT and PSVT. It's ineffective in A-flutter or A-fib. However, sometimes a physician will elect to use it if they're uncertain if it's rapid A-flutter 2-to-1 or SVT. Sometimes they're hard to differentiate. A dose of adenosine may slow it down just a little bit, where the flutter waves will become apparent, or the patient's rhythm will break, and then guess what? It was not A-flutter. It was SVT. We talked about the half-life. We talked about giving it rapidly, 6, 12, and 12, up to 30 milligrams. And there's another video to view if you so wish. Post-resuscitation measures include therapeutic hypothermia to 32 to 34 degrees. That was introduced in the 1950s, and it was used also during open heart surgery. It was uncertain then of the benefits post-cardiac arrest, but it does really provide neurological protection in those patients who are resuscitated, who do not wake up, who remain comatose. It does help to suppress the chemical reactions that cause cell injury and death that are associated with reperfusion brain injury. And the research on that is remarkable. The outcomes are remarkable. It improves neurological function significantly, and it's been adopted by many medical centers. The caution in that is that you don't want the patient to be shivering, because that can cause metabolic acidosis and hemodynamic issues with that as well. So patients who are given therapeutic hypothermia are on the ventilator. They're often given continuous sedation and are given paralytics as well, so that they don't shiver. But make sure, and this is critical, that if you give a neuromuscular blocking agent, even if your patient is comatose, that you also give sedation. Because if that patient does wake up, but they can't move because you have paralyzed them chemically, that is known as a locked-in syndrome, and that would be absolutely hideous to experience as a human being. So make sure that if you're giving vinacronium or Norcuron, that you're also giving sedation. There are 2 videos here for you to view as well that help to show how it's administered. And in some states, in some medical areas, it's started initially with EMS. And the outcomes, again, are really impressive. If you get a chance, I would recommend that you watch the video on this particular slide, because it shows 2 cardiac arrests that arrive in the emergency room at the same time. One survives and one does not. And it shows the factors that promoted survival and what happened to the one that did not survive. It wasn't anyone's fault, so there's no blame there, but it really helps to show how both arrests were managed appropriately and how outcomes can differ. Anyway, that ends this video.